perhaps while we're waiting, maybe we can just, I think there are going to be few participants.
Yeah.
Maybe we can just get a sense of who's there.
Yes.
Shall we start with the Diamond Center? And if you could just introduce yourself and tell us who you are.
My name is Claire Sauvé, and I work for the Physician Health Program, which is centered here in Vancouver, and I coordinate the education programs. So, thanks.
Well,
Hi, Claire.
Hi.
Sarah Dobson. I'm the research manager at the Center for Health Education. Hi, Shafiq. I have an interest in health advocacy, and I'm sitting on the Social Accountability Working Group for curriculum implementation. So, that's fine.
I'm Stéphane Voyer. I'm an internist here in Vancouver. I'm a clinical educator fellow at the Center for Health Education Scholarship, and I sit on the same working group as Sarah in terms of social accountability.
Excellent. And then at UVic.
I'm the Associate Dean of Professional Development, and I'm the Interim Director for the Evaluation Studies Unit, and I'm the faculty rep on the Physician Health Program.
Oh,
excellent.
Super.
And we don't have anyone from UNBC, so it's a nice small group. I mean, ideally, it would be nice to all be in one room face-to-face and have a dialogue about this, but certainly that's not possible. At least we have the technology. The title of our presentation is based on Dr. Lisa Mu, who's a community medicine resident at St. Paul's, right?
Mm-hmm.
And this was the title "Inspiring Advocacy" was a title that was used for her research.
You have to turn his computer on and off because your computer is not doing what it's supposed to do.
Okay, our computer's not doing what it's supposed to do, so it'll go on and off, and we'll continue talking. And what she did was and Farah is going to go into much more detail about the study. Both Farah and I supervised her work, and her project is part of a larger project that's funded by the Royal College on conceptions of health advocacy among the different specialties here at UBC in the Faculty of Medicine. So what we have planned out today is a presentation by Farah on some of the key findings of Lisa's study, and then her own reflections on those findings from within the context of her work. And then I will talk about some of my experiences in presenting about the health advocate role across the different specialties. So I have a few case studies, some of the challenges that I've experienced, and then I'm hoping that we can have a discussion about the health advocate role and perhaps other non-medical expert competencies and the opportunities and challenges of integrating that into a residency training or even undergraduate medical education.
And I wanted to ask, while we're waiting for the technology to boot back up, who here of our nice small group considers themselves to be a health advocate? Hands, a show of hands. Does anybody here consider the work that they do to be within the realm of health advocacy? I guess right now we can see you, Vic.
I guess I kind of do. Oops.
Okay.
Yeah.
Okay, great. And can you talk a little bit about the work that you do in health advocacy?
Most of the work that I do with the Physician Health Program is centered around encouraging physicians and trainees, medical trainees, to consider their own wellness. In particular, with regards to mental health and burnout prevention and getting along with each other. And I guess I just consider that as part of advocacy, advocating for the wellness of physicians and medical trainees.
Super, thank you. Yeah, well, what we're going to talk about today is partly how the definition of health advocacy is still something that is quite wide open, and there are many definitions that are out there, and from the work that we've done, we've seen that really there's quite a wide spectrum of what is health advocacy work, and the kind of things that you're doing to improve the health of physicians would certainly be within that spectrum. we'll talk a lot more about things at various other aspects of the spectrum as well. Anybody else consider themselves to be a health advocate?
Or if you know of someone who does advocacy work in healthcare and what that looks like.
What we're going to talk about today is our resident study, Dr. Lisa Mu's study, where she identified people who did consider themselves to be health advocates and interviewed 9 of them. And so we'll talk about how they defined health advocacy and how they talked about health advocacy education. And then we'll talk a little bit about health advocacy at large. And maybe what I'll do while we're still waiting for the technology, because I found in my many years of teaching, sometimes the technology can really stall something. So I'll just talk a little bit about one of the things that really inspired me to become involved in health advocacy, and I'll tell a little story about my work in Mexico. I did some work a few times in a little village in Mexico called Ajoya. And there was a health promotion project there, as well as a disabled village project there. And I was working in both of those projects many years ago when one of the young men, a 25-year-old, got quite inebriated. He drank quite a bit, and he thought he was Superman, and he jumped off a 60-foot cliff. And it was very tragic because he had severe brain injuries and severe head injuries. And the village health team where I was working, which was basically a group of volunteers from around the world and working with Mexicans, drove him to Mazatlan, which is the nearest center to the hospital. And in Mexico, most of the healthcare services are private, so they're paid for out of pocket. And the young man's family was completely unable to pay really any fees at all. And so he went from the hospital back along the windy dirt road back to the place where we were working in the health center. And we basically helped him to die as kind a death as he could die over the next 10 days. And it really taught me in analyzing this young man's life how important it is to look at the social determinants, because his life was so configured by his social circumstances. His mother was a single mother. There was no land for him to work on. There was a lot of factors in his life that really contributed to making his death so painful and so difficult. And so one of the things I wanted to talk about later is this question of, but why? But why did this young man die? And in the end, when you ask a lot of the questions about why somebody in that situation died, he died essentially because his life was determined by poverty and situations that were really very difficult for him to control all by himself. So when we look at the social determinants of health and poverty and unequal social status, we're really starting to grapple with what we can do as health advocates. So one of the tools I think that we can use as health advocates is this tool of asking, but why? But why did this young man die? Did he die just of brain injuries? Did he die in the end because he didn't get access to good medical care? Did he get drunk that day because of his frustrations in his life? So asking those questions of ourselves is really important. Okay, great.
It's here as well.
Super. So we're here today to talk about inspiring advocacy amongst residents. And as Shafiq mentioned earlier, our resident Lisa Mu did a study with 9 residents or people who had recently completed their residency who consider themselves to be health advocates. And so she asked them questions about what kind of work they were doing and what had inspired them. And our primary questions were really about what is the role of residency training in inspiring residents to become health advocates. And so the findings...
Next. Tell him next.
Okay, so next, down to findings. So this was a qualitative study And basically our question was, what inspires family medicine residents, educators, and physicians to engage in health advocacy, and how can we meaningfully incorporate health advocacy into medical training?
Next.
Thanks. We used in-depth, semi-structured interviews with a purposive sample of residents, physicians, and educators.
Next.
Yeah.
And next once more.
Okay.
Next.
So when we analyzed our results, we found that in fact most of the people we interviewed hadn't really learned a lot about health advocacy from either medical school or from their residency training. The inspiration for most of these 9 people came mainly from outside of medicine. People talked quite a bit about their own families, they talked about their parents being role models, and they talked about other role models, family friends, teachers, some people talked about their church ministers, all kinds of other role models. Frequently mentioned were people's travels in the South World or the Third World, and seeing some exposure to inequities around the world really made a big difference. Next. And that being stated, there still were some pivotal moments within medicine which people did find inspired them towards doing health advocacy. So I'm just going to read a quote that one of the participants told us. That person said, "There was a program that we were encouraged to apply for that had us volunteering in this inner city health clinic. It gave us the opportunity to live in a northern First Nations community. Then another experience was living for a summer in rural Mozambique. I was excited about that program and found another sort of community of people who were interested in working in marginalized communities, but also working on changing health status and improving health in those communities. And that became a very formative part of my medical education so far." So indeed, residency is potentially a place where health advocacy training can inspire our residents. But when we asked residents, when Lisa asked residents, so how do you feel about having a formalized health advocacy component to your residency, most of them had mixed feelings about it. They didn't feel that residency was particularly a great place to have a big emphasis on health advocacy. They felt that clinical skills were by far the predominant skills that they needed to learn. And one of them said that residency is a time when the focus is on developing competency at clinical practice. Learning about advocacy may therefore not be optimal or even as good as it is in medical school when students are less stressed with the day-to-day aspects of providing care. So quite a few of the participants talked about medical school as being a better place to have that kind of training earlier. They did, however, say that there was room in residency, but they said that it was somewhat opportunistic, and they said that they had to negotiate that. They said that their research projects were an ideal location for it, and that certainly that's indeed what our resident herself did. She did her advocacy project as part of her study, and that was a mandatory part of her residency training. Participants in the study noted that there was a fair degree of verbal support for doing health advocacy. They got lots of people saying, yes, go ahead, that's excellent, we really support it. But they didn't find that within the curriculum or within the residency itself that there was much time, and there certainly wasn't a lot of funding, and they didn't find that there was other support. They didn't find that there was necessarily a lot of expertise or other kinds of support for them to pursue their advocacy activities. They mentioned time and time again in the interviews that health advocacy was a less valued activity because of its paraclinical nature. And that certainly is a theme that we've found doing this work in health advocacy, that clinical competency, clinical excellence is by far the center of what a physician and a surgeon does. And health advocacy is typically seen as something that's on the edges of that or at the outside of that. And that's very understandable and makes a lot of sense. So how do we grapple with this idea then of integrating health advocacy into the curriculum? In this study, participants talked a great deal about having the need for more time and flexibility within residency curricula, that it was really important to allow residents who really had an interest the time to make a little bit of time within the curriculum and to be flexible with them, as well as focusing on things that already exist within the curriculum and perhaps adding new things. They suggested health advocacy-oriented research and electives. They also suggested having long-term or longitudinal residency structures which give residents control over their own schedules. So I'm sure you know a lot of residents don't feel like they have much control over their own time. So that's harking on that particular issue as well. And they also mentioned the possibility for doing part-time residencies as a way of integrating health advocacy into the curriculum and giving people an ability to do something that might have taken a longer time or might have involved traveling. So that would also build in some more flexibility. One of the things that most of the participants in the study talked about was the importance of having peers and mentors. Particularly peers, having a community of practice of people who are really engaged and really interested in doing health advocacy was really important. So having that excitement, that buzz, being able to talk to other people who were passionate was really important. And one of our participants said, whatever one gets involved and passionate about, if there's people to share that with, it becomes very important. You realize how important those friendships and connections are. I realized that a group of people that I worked with, I protested with, or, tried to change things with, often came up against big roadblocks. Those are hugely bonding experiences, and that's really become my community, and that sustains me a lot. So this particular participant talked a lot about developing a community around health advocacy. And so I think our participants had some really, really good ideas about how to foster health advocacy within medical school in general. They also talked about the need for mentors, faculty mentors, clinical mentors, and other mentors. We know that that residency education does provide an opportunity for health advocacy efforts, but it has a limited role at this point. That could change in the future, but what we found from our study is that those residents and current practicing physicians who are health advocates have already done a lot of health advocacy prior to coming into medicine. So what I take away from the results of this study and from our e-booklet work that we did on health advocacy is that there's a spectrum within healthcare, which really is the same spectrum that health advocacy can look at. And that spectrum is not new to any of you. There's that spectrum that starts with health promotion, disease prevention, treatment, and palliation. And so we're going to look now for the next few minutes at the role of health advocacy within this spectrum. Typically, when we talk about health advocacy, we hear a lot of concepts of working upstream. And health promotion really is that place where we talk about working upstream. And upstream means looking at the determinants of health. And there are many, many determinants of health. I've just named two of them here because those are two of the ones that are discussed a lot. Income is one of the biggest determinants of health, and so are social status inequities. So working upstream means changing unequal social structures, dealing with issues like poverty and racism and sexism and these things that make people unequal in society. Working upstream means moving towards sustainability, moving towards justice in a sense of the environment, the economy, and society. So these are really big, big issues, and they really take us outside of the realm of clinical medicine. Within this whole move of social determinants of health is an international movement, and Canada is part of it, called Health for All. And really, when we want to look at very, very large scale changes and really, really want to look at health promotion for everybody, it involves changing the structures which create income inequities, which create inequities between people. And there are a few places in the world who have very successfully managed to implement these kinds of large-scale changes. And I won't spend a lot of time talking about them, but I will mention that Cuba and the state of Kerala in India are often used in my field in public health to explain how when we make large-scale social changes that improve the access to education and housing and social services, and when they give everybody more of an even playing field, that they really make a massive impact on health status, and that basically all of the statistics for Cuba and Kerala, despite the fact that those are South World nations, they look much better than the countries all around them. So when we talk about health advocacy on a large scale level, those are two good examples to look at. We can also ask ourselves, what are the roots of health? What is this concept of salutogenesis? What is it that really creates health? And earlier I talked about a young man who lived in Mexico and whose life ended tragically because of the situation that his family was in, and his frustrations with that, and how he drank too much and ended up jumping off a cliff. And I think it's really important in health advocacy to ask ourselves those questions, to get right down to the roots, to ask ourselves, what are the roots of health? And in many cases, to really improve health for all in this huge and all-encompassing way, we probably need more than advocacy. And maybe we need to ask ourselves a little question even about the terminology of advocacy. Many people associate the concept of advocacy with lawyers and with the work that lawyers do. Now it's been taken to a much broader social realm, and we need to ask ourselves whether that works for health and whether it works for medicine. Perhaps it does, and time will tell whether we continue to use that term or not. In the old days, we used to use the term health promotion, and now that's been changed. So terminology does tend to change as time progresses. In Canada, we have had some very, very successful campaigns that have used these really broad-scale social changes in a very, very successful way. We've managed to be one of the world's leaders in anti-smoking campaigns, in seatbelts, in drinking and driving. And in doing so, we've managed over decades to incorporate legislative changes, campaigns moving towards social and behavioral changes. We've changed social norms towards healthier behaviors. We've used a carrot and a stick approach, meaning that people get punished if they do the wrong thing, and they get incentives to do the right thing. And within these larger campaigns, there has been a role for physicians and surgeons, but there's just as big a role, or perhaps a bigger role, for governments and other professional groups. So all of that to say that when we look at health advocacy, the importance of working together with various professional groups cannot be underscored enough. Successful Health for All campaigns incorporate a few integral elements, and I think one of the discussions and the subtext of this work that we've been doing with health advocacy in Canada is this one of political will. Is there political will to examine this concept of health advocacy at the bigger level, at the deeper level? And I think at the heart of this debate in health advocacy is one of political will. Do we have the will to really make the kinds of changes that we want to make? So I encourage us to sort of think about that as we have our dialogue later. Other elements that make for a successful Health for All campaign or program are involving the people, particularly the patients, having cooperation within one sector, typically the health sector, as well as within other sectors. In the health sector, we know that we really need to work with education, we need to work with a lot of other sectors, and we also need to work with appropriate technology. So that's a discussion of health promotion and health advocacy within health promotion. Let's look briefly now at the other elements of the spectrum of healthcare and just quickly talk about health advocacy within the other aspects of the spectrum. So in disease prevention, there's also a great role for health advocacy in encouraging people to get screened and tested, to educate people to live a healthier lifestyle, and for lifestyle modifications. All of these are really effective health advocacy initiatives. Within treatment, there is another huge role, and this is probably the place where clinicians play the best role in health advocacy. As we know, there's an ever-expanding clinical territory. There's lots and lots of new treatments coming out regularly, lots and lots to read in the literature, and this in itself is a very, very important part of the healthcare spectrums. We know that generally that hospitals and clinics and the medical system itself works very well. But what we've learned in talking to the physician health advocates whom we've interviewed is that this is the place where they typically feel they have the most power to work as health advocates. So health advocacy does help the system to work better, whether it's families advocating for patients, clinicians advocating for patients, or other people advocating for patients. Finally, in the spectrum of healthcare, there's palliation or palliative care. And this is an area which we're slowly moving into really successfully in Canada. It's a growing area within the healthcare spectrum, and it certainly is one that shows a lot of promise for health advocacy. Assisting people to die with dignity, there's also a movement for people to die at home, and a way of finding peace at this end of life period for patients is really meaningful. And the importance of having health advocacy for this particular part of the health spectrum can't be overemphasized, because we know that patients have told us for a long time that they want to die in different ways than they are currently dying. So I just want to reflect a little bit now on this whole idea of health advocacy, and especially the really, really big questions that we're asking about changing systems, changing the whole social system in which we live in. Because really what I talked about earlier, health promotion, that really big upstream work, it typically is where we talk about doing this kind of work, starting right at the root, going right to the bottom of it all. And I want to just talk about the challenges of doing that. It's not easy. It's really hard work, and it requires courage, because we're trying to challenge a social system that's very well entrenched and that is something that people are already accustomed to. It involves some kind of conflict, and conflict is difficult. A lot of people don't like conflict, and managing that kind of change is very hard emotionally and socially. And I also want to look at the fact that there are lots of other professions who could be working on changing systems. Lawyers could be looking at creating more justice. Engineers can be looking at creating systems in the world which are better for everybody. Teachers, there are lots and lots of other professions who could and already are working on changing systems. And that this does, as I said earlier, need to be something that's done with a whole variety of other groups. Within the university itself, we also have challenges. What are the challenges of teaching upstream health advocacy in a university setting? Since about the past 2 or 3 decades, our funding structures at the university level have come less and less from government. So we've had to increase tuition and had to move towards trying to find funding sources from other places. That creates its own challenges. Furthermore, the university itself is, according to some people, already embedded within hierarchies that exist within society. Is the university's role to reproduce the social system within we live in, or to challenge it? And there's really no easy answer there. Some faculty members do believe that the university's role is absolutely to challenge the social systems which exist, for the university to be the vanguard of social change, and for those of us who are very well educated to lead the way. Other people think that it's just really important to crank out students to find good jobs and to not challenge the social system at all. These are really important questions when we're talking about health advocacy. So what is the role of the university and residency education? And all of these questions and these challenges make the teaching of health advocacy, particularly from within a health promotion framework, quite challenging. So when we get back to the topic of our talk and our study, inspiring health advocacy, within the health advocacy spectrum, where is the best place for physicians and surgeons to work? And I ask you all to think about that, and to think about how you, if you are faculty members or if you are involved in residency education, where you encourage your students and residents to work and how you're encouraging them to work. Thanks a lot. I'm going to hand it over to Shafiq now.
Certainly. Actually, before we go to me, any comments or questions for Farah or about the study?
Yeah, great.
I have a couple of questions. The first one is about Lisa's study, and when she was asking the residents about some of the suggestions about how to incorporate health advocacy into residency training. One of the suggestions was around advocacy electives. And I was wondering, given the different definitions of advocacy, whether the residents actually had any suggestions for what that might look like.
Well,
I'll ask my second question in a second.
Oh, okay, thanks. A lot of the participants talked about how important it was to be located, if you were interested in health advocacy, in a setting which served marginalized populations. So electives that flow in that kind of a setting are quite natural. So if there are people who are dealing with addictions issues, or people who are involved in the sex trade, or like we have here in Vancouver, an excellent service called Sheway that works specifically with women who have substance abuse issues and they're pregnant. Those kinds of opportunities kind of emerge quite naturally if there's already a cluster of residents working in an area where there's already some aspect of marginality, or something that offers lots of opportunities because there's so much need.
Remember, she also interviewed she interviewed 4 family medicine residents, 3 physicians, recent graduates, and 2 educators. And I suspect that if she had interviewed residents from different specialties, she may have received perhaps a broader conception of advocacy, which is something that I'm also getting from my own study in this area.
Great. Please ask your second question.
All right, well, it's sort of a half comment, half question, I suppose, and it's just around that idea of where the best place is for physicians to do advocacy work, where along that spectrum. And I suppose, sorry, I'm just gathering my thoughts for a second. I've lost my second question. I'm just wondering about one of the conversations that we had in the implementation task force around social responsibility, when undergraduate students are confronted with marginalized populations and vulnerable populations, one of the responses is, well, what are we supposed to do about that? And I imagine there's a similar response among residents that we've sort of seen in the literature a little bit. And I suppose I'm just wondering to what extent it would be tied in with professional identity to take on some of those bigger upstream issues, as opposed to, as you mentioned, working in the treatment area and having that direct impact with a particular individual patient. And so, to what extent should that be fostered in among physicians? I'm not a clinician, so I don't know. I'm wondering.
I think you've hit on a key point. As I go from specialty to specialty, doing academic half days for residents in different specialties, many will want to look for good examples within the context of their specialty. We just haven't created the space in postgraduate training to enable them to do that. One place that I encourage residents to go to is in the editorial sections of the journals in their specialty. And that's where people write about advocacy. They may not call it that, but that's what they write about that. And in some programs, there is a focus. For instance, just recently I was giving an academic half day for neurology. And I scoured the literature, and there was plenty of stuff. Interestingly enough, our residents are not exposed to that literature in their own discipline. So it's not as if there aren't ideas out there. I think that we haven't created the space in medical training to begin to search and look for ideas, who within your particular specialty is doing some good work that you can begin to connect with and build on.
I think it's just a really important question. So which part of the spectrum do physicians and surgeons work best? I think the answer has to be, it depends on who that person is. So whatever their own interests are, and who they are before they came into medicine and who they are today after their training. I guess it seems logical, however, that within the medical system, physicians and surgeons have a great deal of power. And so in order to try to streamline and make that system as patient-centered as possible and to work as best as possible, there's a huge and really, really important role for physicians and surgeons in the treatment system itself. The skills of physicians and surgeons aren't necessarily honed towards working in almost any of the other three aspects of the spectrum. Anybody else, other people who are trained in various other healthcare or education or other kinds of skills can work just as effectively in the other three aspects of the spectrum. That doesn't mean that physicians and surgeons don't have an important role there. It just means that their training isn't specific to those things. And what I've learned working in this area for the past many months is the importance of underlining interdisciplinarity in working like this. It's really, really important to recognize how many other people are doing really great work in health promotion. So people who are trying to deal with poverty or who are trying to eliminate poverty are doing enormously valuable health advocacy work. They just might not be called health advocates.
Question, did you have a question? Yep.
Yeah, so how do you teach health advocacy without getting political? I mean, a lot of the things that you talked about earlier are quite political. Physicians as a group tend to be pretty conservative. So you've got people who maybe tend to vote for decreased taxes and less government interference. And a lot of the things that are needed require more government interference. So how do you do that without being accused of trying to make the students and residents into socialists?
That's an important question.
And as a matter of fact, if you look at the competencies, there is in the health advocate competencies from the Royal College. There are competencies. There's one competence that says that you want to become aware of some of the tensions inherent in health advocacy, and I think that that's what it refers to. But what I've been hearing from in my interviews with program directors and others is that one way, I don't think people saw it as particularly an issue in terms of being an activist, provided that you did it in a way where you could, it wasn't just activism for the sake of it, but there was evidence to support why making certain types of policy decisions or looking at the healthcare structure in particular ways would ultimately lead to better health outcomes. And so, there's the smoking cessation initiatives, there have had, seatbelt initiatives, all of those have had ramifications where you want to make policy changes at the societal level. Yeah, go on.
So I think I have two answers to that thought, or two reflections on that really important question. The first is it's almost impossible to talk about big system-wide changes and not talk about politics, because politics is about the distribution of power in our society. And inevitably, if we want people to be healthy, we need to be able to share that power. We need to be able to equal the playing field. So I don't ever tell my students I'm a socialist, and I certainly don't try to go into the realm of politics at all. But yet this whole area is replete with political significance. It's in every one of those examples that I gave, from drinking and driving to seatbelt laws to smoking. Politics were really involved. If you hear the behind the story scenes of why Canada became a leader in anti-smoking legislation, things that happened at the Senate level nationally were really, really important. We had people who had conflicts of interest, who were investing in tobacco companies, things like that. We inherently have got to have become political if we want to be successful in those large-scale ways. Yeah. Now, that being said, I just want to quickly finish. That being said, there's so much research which isn't political in nature that points to the effectiveness of doing good health promotion strategies to improve health for all. So if you want to try to depoliticize your teaching with your students, it's really quite possible, because there's so much abundant literature to show that there's good evidence, robust statistics to show that if we involve policies where people get access to housing, access to jobs, and better income, that we'll have a massive impact on health status.
Yeah. And also the idea of politics in my own research has emerged to enable healthy debate. I think in DPAS just a couple of weeks ago we had was it Brian Day who came in? And so when you're talking about healthcare resource allocations, those are all political. When you're talking about engagement with pharmaceutical industries and what do you do that? Those are political decisions. What research gets funded and where the priority is, how much do we allocate to brain research or to cancer research? And how will resources in Canada, research resources, be allocated to fund that? I don't think that politics is outside of that. Perhaps it's not in your face, but it's still very much a part of the decision making. I'm just going to, I won't have time to go through my presentation, but I'll just tell you what some of the challenges have been in my work with the residents so far. So this is how I typically start, you can see the case study, start my presentations, because there are faculty, many faculty are usually present at the rounds that I give. And I start off with this case study. Your department has recently had a Royal College review and received accolades for strengths in the medical expert role. I think that that's unanimous across our disciplines. However, the department has been cited for deficiency in the health advocate role. Now, this is a real case. The residency program committee is gathered to discuss the matter. The committee has brought in an expert for advice. So this is how it typically happens. I get a call saying, you know what, we were told that we need more of a focus on health advocacy. Can you come and do a lecture? And then they can tick it off and say, we've had someone come in and talk to us about health advocacy. The expert suggests that efforts to integrate health advocacy in the training program is likely to be more effective if it's undertaken using a participatory approach. In other words, actively involving the residents. The committee is convinced and decides to involve the residents in reviewing the identified weaknesses in the curriculum and to develop a plan to correct these with a focus on the health advocate role. I think what's implicit here also is that, what I'm advocating for is a much more meaningful engagement of our residents in this process to help, because if you look at the competencies, they're very broad and open to interpretation. And each particular discipline, I think, can really take it in a direction that they feel would be most fruitful. Next. Whoops. Oh, no, that's fine. So a session with the residents is organized, and the expert gives a passionate lecture on health advocacy, perhaps not unlike the one we gave today, and invites questions at the end. Right? Now this further reinforces that this data that I've gathered is separate from Lisa's study, but it's complementary. Next. After an awkward silence, one resident has the courage to put their hand up and says, health advocacy is very important, but we really need to develop proficiency in clinical and surgical skill. The other stuff we can figure out later, once we get going in our careers. And several residents nod in agreement. This is not uncommon. And you know what? It perhaps is not even unreasonable. And so we need to really think this through. I'm not suggesting that we favor, one set of competencies in one particular CAN-MEDS role over others. But I think we need to, as educators and researchers, along with residents and others, think through how will we meet our responsibilities in this role. Any ideas that you would have to share with respect to this type of reaction? Okay, I'll just, as you're thinking about that, I'll just go on. Next. And then we can talk about this. What we're hoping that this session will be is an opportunity to continue this dialogue, at least among the few of us who are here, and perhaps invite others over time to do this. So, some preliminary findings from my own study is that many residents across disciplines are not really aware of the health advocacy competencies. They're now beginning to become aware when people such as myself are invited to talk about the health advocate role. It's certainly not being seen as a meaningful part of residency training. Many of the residents have told me that there are few of any mentors that they can emulate. And again, really need to develop proficiency in clinical. So there's a real anxiety over that. Next. So when I went to the neurology rounds, what I started to do initially was to gather some literature on where I could find examples of what some good researchers out there publishing in neurology are writing about some of these issues. And here was just one example that I found. And it talks about how more than 25 million people in the world are affected by dementia and suffering from Alzheimer's, and points to increasing evidence that points to the roles of vascular risk factors. And they look at the possible, and I've highlighted this in yellow, beneficial roles of what they call psychosocial factors, right? High education, active social engagement, physical exercise, and other such factors in the pathogenic process. And if you go down, and it looks like socially integrated lifestyle issues, and other social determinants of health. So when you begin to uncover literature like this, we need to begin to share this literature with our residents, and then have a dialogue about, well, what are other researchers in your discipline suggesting, and what role neurologists have to play in this. And so it's that level of, I think, dialogue that in and of itself is a movement towards achieving your health advocate competencies. We have to develop, I think, begin at the very basic level, just providing opportunity for dialogue. Next. So, I go on to real clinical cases. That's what inspires our residents to begin thinking about the implications of the health advocate role. So here's a case that this article starts with. A 12-year-old, if you need to go, you're welcome. Farah has to go, but you can always email comments to her.
Yeah.
And we have about 5 more minutes. If this is helpful, I can finish with some of these examples.
Okay. Thanks a lot, everybody. Bye.
So here's one case that I started with at the rounds with the neurology student. A 12-year-old immobile tooth-fed GMFCS level 5 spastic quadriparetic child with cerebral palsy was brought to your neurology clinic for a scheduled follow-up. Examinations reveal multiple cutaneous lesions. And then I ask, well, what do you think that's due to? Right? And so, of course, you get a flurry of discussions around that, because this is where a bulk of the training that they've had has been around. And next. And then I reveal that upon further investigation, it turns out to be rat bites. What do you do? Now, when I presented this last week to the neurology residents, they said, well, in the hospital setting, it's much easier because there's a team around you. You can certainly begin to consult with a social worker and with others in the team to begin to think about where we go from here. But once you get outside of the hospital setting, that's where it can become a challenge. I surveyed the neurology residents and asked them if they knew about the Red Book. I don't know if you've heard about the Red Book. I suspect that some of you have. Most of them had not. Just one PGY1 resident had heard about it. So these are the types of resources that some of our residents are not aware of. Next. Another case, a 4-year-old child presents with severe global developmental delay without apparent etiology despite detailed investigations, including metabolic, genetic, and neurological imaging studies. What do you think is happening? Again, immediately it inspires a really nice, rich discussion about what might be happening. Next. At follow-up, it's made known that previous home educator and rehab services visits have now been suspended because of an extensive cockroach infestation in the family's rental apartment. What do you do now? And it's funny, when this comes up, the discussion is not as rich because people have not been given an opportunity throughout their training to think about this. And then we say, okay, let's take a step back. Who might we call? And then the discussion moves into, well, we don't even have time to call. And then the discussion moved into, well, spending time on these things isn't even billable. So there's this whole notion of there isn't a fee code to allow us to at least dedicate some time to do this. So that's another level of anxiety or concern that some of the residents express. Now, I think that at the end of the session, when I asked, was this helpful? They all said, yes, for a start, it was very helpful because it gave us a sense of what some of the limitations are. But now to leave us here is also quite disconcerting because we want to know, what can we do? Our residents, when you train to be a healthcare provider, most, if not all of our future physicians and healthcare providers want to be able to make a difference. They don't want to feel paralyzed with this. And so I think our responsibility at the level of training is to begin to explore with them, how do we go about doing this? Next. So this is something that I found can work to stimulate dialogue. And this is something that's, that we tried in our social responsibility and accountability group as an exercise. And I think it was a really worthwhile exercise because it really got people to start to think about and talk about social responsibility in this way. Next. And then, effective ways to integrate health advocacy competency into training are. So it's already 1 o'clock, so I'm going to stop here. But if I had more time, I know we got hung up a bit. This is the type of exercise that I would want to all of us participate and begin to think about. Well, what might this look like in postgraduate training? And one thing that I'm learning from my studies and from Lisa's study is that one potential effective way is to engage our residents right from the outset in helping to co-develop, sort of requirements or a curriculum in health advocacy that complements the medical expert role, and it's not seen as sort of something over and above what they're already doing. I think to impose something top down is not likely to be successful, and there are other very good examples of top-down approaches that have not worked in medical education. With that, I'll probably leave the final comment with you, and we can call it a day. Hopefully this has been helpful and useful to you. Any comments? Yes? And you, Vic?
Yeah, thank you very much, Shafiq. I really enjoyed that. I think often when people talk about health advocacy, students and even residents think about going to the third world or the downtown east side or remote Aboriginal community. That's more interesting. But actually, a health advocate isn't isn't a competency that you can just say, well, I'll only use it at certain times. Like it's supposed to be there all the time. And I think the challenge is to help people figure out how to be health advocates where they are in their own practice every day.
Absolutely. At the individual patient-doctor relationship, at the patient-doctor-family relationship, and then you start moving into community and society. And at that larger level, I think that's where partnerships with other organizations, with a larger specialty organization can come in very handy. But I think you're absolutely right. Yeah. At the Diamond Center, any comments there? Or parting words? Okay. Well, thank you very much, and thank you for attending. And if there are any other comments that you wish to share, please don't hesitate to email me or Farah, and perhaps even comments on our presentation and how this could have perhaps been more richer, if at all. Thank you.
Thanks.
Okay, bye-bye.
Thank you.